So, Kevin, I don't think really much anything at all happened last week. I think we can probably just call it a day, say hey, and call it a day.
It is quiet times in general in the world these days. No need for more people talking about what's going on in the world.
I think, there's like a lot of different places we could start, but it feels like access is probably the biggest and most ongoing conversation. So I thought it might be useful to go back in time a little bit to December 4th, 2025. There's a quote from Dr. Oz, and he said, "We want to pay enough money that this becomes an interesting opportunity for sponsors all around the world." I say that with a great desire to highlight that we want people to make money building these solutions. We're open for business. We want you to be open for business. And then the access rates came. Kevin, did you feel like those rates said we're open for business?
Well, I don't know that I know the financials enough personally to like when they came out, it was like, okay, they seem lower than what people expected. That obviously was the reaction on LinkedIn, social media, so on and so forth. And the general sentiment at the time was seemingly what gives, right? We've got MSK companies that are charging what, $1,000, and all of a sudden Access comes out with its rates, and it's an order of magnitude almost lower than that. So I think the general overarching reaction was, "What's up with these rates, Martin?"
I think that the what's up with these rates question is a good one because if you actually go back to the commentary at JPM, they were pretty explicit about what they wanted to do here. And so you wrote in some of your JPM coverage, and now I'm quoting not Dr. Oz, but Kevin O'Leary, saying that they're paying incumbents in a way so in a way so that they have to adapt or die, and encouraging insurgents to bring more innovation in and drive that change faster. And yeah, that's what these rates are signaling, I think, is not we're just gonna throw money at stuff, and the incumbents that they're talking about ended up not being, you know, the physical therapy companies of the world, but Hinge, basically.
Yeah, I mean, I think it was Klump who was on stage at JPM who was talking about what the access rates were doing and how they perceived that inside of CMS and CMMI. And yeah, I mean, this was the topic of conversation this weekend of that I wrote about in the newsletter. I was like, listen, if if we were sitting at CMMI and we were trying to design a program like Access, you know that the market is watching you. You know that everybody is paying attention to the rates that you're going to release. And you know what going rates are for these various digital health tools. So in publishing these rates that are so much lower than what the digital health industry, what incumbent providers might have expected, you know the reaction to that's going to be negative. So if you hold that to be that seems likely true, right? Um, and then you think about the fact that CMMI needs participants to actually make these models go. If CMMI releases a model and the entire industry says thanks, but no thanks, these rates aren't good enough, that's not good for CMMI either. They need participants into this program. And then so it's like, what are they up to, right? And to me, the most logical thing is not that they mispriced this, that they got that wrong, because that's a pretty simple math equation that I'm sure they went out and had conversations and understood where digital health is at. I'm sure they understood what they were pricing it at. I think the much more likely scenario is that this mirrors what we've heard from HHS leadership, from CMS leadership, from CMMI leadership, that they view this as a transformational moment in American healthcare. They want to incentivize the adoption of new AI centric care delivery models, new remote monitoring technologies, new consumer grade wearables in healthcare. RFK last summer included he was out saying he wants every American to have a wearable in the next couple of years. And it's like, okay, so if you think about how to facilitate that change, I actually think they're trying to push for that with access. And they are trying to roll out a really meaningful program that, if you do the math on it, like this is billions of dollars of potential revenue for somebody to go get if you can figure out not how to do the math coming down from existing rates of healthcare delivery, but I think it's going up from zero using technology. And I think the bet on CMMI's part is they know that there are participants who are going to come in and be able to deliver care at this cost basis, right? Which is kind of wild to think about, both for this program, but also for the what's it called? For the spillover effects of the industry, right? If I'm an employer and I'm looking at this, and by the way, CMI also announced on Thursday that payers signed up for this in mass. I think employers, if they're smart, they're going to be looking at a program like this going, oh, all of a sudden for these tracks that Access is covering, these are the rates. Why am I paying $1,000 for MSK when there's options that are a tenth of the price? And I think that's how that to me is the theory of the case here, which I think is really interesting.
It's an exciting theory of the case, and I think that the big question is, does it work? And
Mhm.
this seems to me like the sort of big bet that you want CMMI to be making or to be pushing for, is saying, I mean, if you think about Talkspace, right? Because Talkspace was, I went and I said, okay, Talkspace, Hinge, and Omada, what is their PMPY? What does that look like compared to the access rates? And if you just think about what a social worker or a therapist costs, and you figure, like on an hourly basis, maybe $150 an hour if cash pay, less if they're in network for insurance. And the access rate for behavioral health is 180 bucks.
Hmm.
That, maybe covers one session of cash pay prices with a therapist. And so it has to be something that is a lot less labor intensive than traditional talk therapy. And Talkspace spent a good amount of their time at JPM talking about their proprietary model that they're working on. And they're
Hmm.
figuring out, okay, some universe of the world is always going to want talk therapy, but what could we do that is not talk therapy? And they didn't call out access, but you know, if you say we have created this AI therapy and I don't know, like maybe that's for the Medicare population, 180 bucks a year is
Yeah,
sufficient to get them interested. So I don't know. I thought that it was like a sort of interesting to kind of watch those conversations ebb and flow on LinkedIn
for sure.
and social media.
Yeah, totally. I think it's going to be interesting to watch too over the coming months how this program continues to roll out, who does end up participating, what those organizations look like, what sort of changes they make. And I think most importantly, how CMMI and CMS continue to support this program. Like, if this is indeed intended to be huge transformational change, billions of dollars of revenue for people to go get to deliver care for chronic condition management in a fundamentally different way, bring that into Medicare, start driving change in the industry, I'd expect we're going to see a lot more publicly said about this program and supporting it. And I think it'll be interesting to watch how they choose to do that, how they roll it out, who they try to keep on their side in this program. It seems like ACOs, value-based care organizations are looking at it going, maybe this is good for us. Like maybe we can wrap this in and figure out how to offer this with in a way that we can deliver profit on it. And you can imagine the like if I'm a traditional PCP and I can manage my panel of patients and all of a sudden I can now be incentivized to refer them out to, my diabetes patients go get this app, mental health this, it allows me to make more money and makes my life easier. That seems like a pretty compelling value prop for them to continue massaging over time and figure out. So I'm excited about it. I'm curious to see where it goes from here.
Yeah. The other big piece of the news last week, which we covered on an emergency pod, was Humana's earnings. So they're growing a ton, 1 million people, which is a lot. Uh, but late breaking last week, they also announced a billion-dollar acquisition of a provider group in Florida called Max. What do you
Yes.
think about this, Kevin?
It's an interesting move given the times, right? I was not expecting going into the week that we'd be writing about $1 billion acquisition of a value-based care provider, right? Third year of V28, advance notice just came out a few weeks ago. It's a really tough time in the value-based care market. And you did the analysis in Slack, right? back in the heyday of value-based care when Oak Street was acquired by CVS, it was what, 60 something thousand dollars per patient that CVS paid to acquire Oak Street. That even at the time was pretty like, you talk to industry veterans and they're like, this is way out of what valuation should be for MA, and it was what it was at the time. Um, the market clearly has changed a lot. This valuation was not at 66,000 bucks per value-based care life. I think it was closer to just over 10,000 a life, right? But nonetheless, it's an interesting indicator of what Humana is up to and the opportunity it seemingly sees to make moves while the rest of the industry is retreating and focused on profits, and make a big bet to win in Medicare Advantage in the Florida markets where this group operates, which again kind of goes back to this overall thesis we talked about on the pod. Humana's either got this right and they are really well set up over the next couple of years. They're timing this market right. They're acquiring members at the right time. They're going to be able to retain them, or they've got it wrong, and this is just compounding the issue. Interestingly, if the market does turn around, like, it's still back to the conversation we had, it still sets up well for whoever's running Humana going 27 into 28 and beyond, assuming that MA comes back to some degree, right?
Yeah, I think so. I mean, it seems like they got a deal relative to what, CVS paid for Oak Street, which is not perhaps a good benchmark. It does seem like there was a bit of a bidding war. There's some other people kicking the tires on it. Humana came in. They sort of alluded to this in the earnings call, and you know, our ears perked up and we're like, oh, that's a strange thing. We hope to be, Jim said something along the lines of, we hope to be announcing M&A soon.
Yeah.
And I was like, oh, that's what an odd thing to say. I
Yes.
think, I don't, yeah. My thoughts on this are number one, it could be that they have timed the market exactly correct. It seems like a crazy move to me to do this year, given the amount of pressure that they have on their execution. Like large M&A is a distraction, and it's a distraction for everyone in the C-suite and for everyone down the road. Integration's often messy. And so you're not looking at this deal and saying, this is going to help us this year. Because it's not. It's like I
Hmm.
mean, there's regulatory approval, and once you get through all of that, which by the way is a, massive distraction for your executive board. And then you got to integrate the stuff, and that's always a real pleasure. It's like you got 140 new doctors being like, well, hey, my old boss said I could have Tuesdays off. So I don't know what you're talking about, but it was like, I mean, so I don't know. I think that like maybe this like they felt like they couldn't pass on it. It was like a once in a lifetime opportunity for them. But given the amount of pressure on their execution this year and on stars scores and everything that has to go right for them this year, but especially in the next 3 months when they report first quarter earnings, it seems bold.
Oh, for sure. I mean, it's a, I agree. It seems like a bold move. The Play this out with me if you're thinking about this strategically. So we talked about this in the Slack. There was a rumored bid from Towerbrook and Guidewell that was made public back in December as they were looking for loan approvals to do the deal. Guidewell is the Florida Blue plan. So clearly there was some activity in the market that was trying to get this deal done. It seems like Humana caught wind of the deal through perhaps terms it had in its contracts with the provider where they had a right of first refusal or something like that, where Humana then got to see the deal and got to decide whether or not it wanted to compete, swoop in, try to actually win this deal, and they clearly decided to. Um, if I think about the rationale for why not let that go, why do it now? One, if you let it go, you presumably think Florida Blue is going to be buying this asset and it's going to give them that foothold in the market. So you are making a move to to win in the primary care footprint in a key geography in Florida, where presumably, if you are bullish on the LTV of your Medicare Advantage membership, and you potentially are able to look at where that membership is and you see that you've got membership in that book, I can see how you might say, hey, let's let it ride. We're all in on this. If we're all in and we're right, great. This is going to work out beautifully. If we're all in and we're wrong, we're not going to be here anyways to see it through. So let's go all in. And next leadership team, they'll probably still have a good opportunity to figure this stuff out then too.
Yeah, I think my reaction is more indicative of why I'm not the CEO of a large, the swashbuckling CEO of a large insurance company, and
Yeah.
instead recording this podcast is that is frightening to me.
Yeah, it's a big bet there that
It's a
they're placing.
big bet.
The bigger
But
bet is, of course, the MA membership. This is just kind of doubling down on that existing bet, right? The
yeah,
interesting thing, though, so if I was doing the math over the weekend and I was doing it again here as we were talking. So I think the press release said they have 80,000 ish value-based care patients. So if you do the math on like assume it's $1,000 of revenue per patient, that's what 12 grand a year of revenue per patient. That means they're at $1 billion of revenue ish. So they're getting bought for around 1x revenue. A sell side analyst noted they're getting bought for 13, 14x EBITDA. So if you do the math on that, that means they're generating 73 million of EBITDA, which means they're trading it like their EBITDA margin is 7 to 8% in the year, which for a VBC business in current operating market is actually surprisingly high to me. I don't know what I would have guessed before had done that math, but it wouldn't have been 8%. It might have been zero. It might have been like 1 to 2%, but 8% seems like if you're operating at that margin in VBC right now, given everything going on in the market, I can see how that's an attractive asset to bring into the fold.
the other thing that's interesting to this that ties back to the earnings call is the profitability for Humana in 2026 is coming from their like Centerwell.
Mhm.
And this goes back to my execution risk thing. It's like we're going to be trying to pull off an integration for they're expecting like for their to hit their numbers, their earnings per share this year, they need 100, no, 1.5 billion in profit from Centerwell. So this isn't like a critical part of that story. 70 million bucks is like not $1.5 billion
Helpful, but
dollars.
not changing it. Yep.
Yeah. And you also need your insurance to break even. And so I don't know. Yeah, it's like a good story. It seems like they got a reasonable price on the asset. And this isn't their first Florida acquisition, even in the last year. They acquired the Villages health assets. So they are like Florida, man. They are setting up shop in Florida, which is where a lot of Medicare Advantage is, and they're going for it. Good for
Florida
them.
is a unique healthcare market. Yeah, good for them. On the topic of MA growth, I thought it was interesting. There was an article this week in Wall Street Journal. Their editorial board wrote an opinion piece that was notably different than the Wall Street Journal's vibe towards Medicare Advantage in the past, which essentially called for defunding MedPAC. Um, I was blown away. I was reading this and I was like, is this actually, am I reading real news or is this a fake version of Wall Street Journal? Because they have been so oft quoted in DC circles and congressional hearings about how bad Medicare Advantage is. And then all of a sudden, here's this piece being like, no, privatized Medicare is actually a good thing. Medicare Advantage is doing great. This MedPAC group is just screwing with everybody's minds. Martin, what gives in terms of Medicare Advantage versus original Medicare costs? Like, what am I supposed to do to square all of this?
I mean, so my answer is like you can't. Like there's not anything you can do. So MedPAC has a house
I,
view. They
Yep.
have a house view, and that house view is that Medicare Advantage is more expensive than traditional Medicare for the taxpayers. They say it's about 114% in the cost this year. They publish basically the same slide every year, but they update it saying, okay, we look at the benchmarks, the bids, and then the payments, because that's the sort of order of operations for MA payments. And then we add back in coding effects, net of adjustments, and then we add back in selection effects. And so really what the sort of difference here is that MedPAC's house view is that healthier people tend to end up in Medicare Advantage. Is that true? You can argue it a lot of different ways. The It is true that patients with end-stage renal disease are about 60/40 original Medicare Advantage. So most patients with end-stage renal disease are on original Medicare. Hospice costs also all original Medicare. So there's probably some truth to the selection effects, but like, okay, end-stage renal disease is like 400,000 people in the entire country, right? It's not like a massively meaningful amount of people. It's a lot of spend, but okay, so that's like MedPAC's view. The Medicare Trustees Report doesn't explicitly, this is what gets published every year, and it doesn't explicitly say which one is more expensive. You can do some math, and so they say it's about 50% of the enrollees are in Medicare Advantage, and then they have payments to private health plans, and you can kind of break that up into a per member per year amount. And MA ends up just being a little bit more expensive, about $1,000 a year. The
Hmm.
funny thing about this is the trustees report says, oh, it's about 50. And then you look at press releases and it'll like from the same year and it'll say, oh no, it was actually 54%. And so it's like these are like how you account for what percentage are in traditional Medicare versus Medicare Advantage is also a hotly contested subject. And then you have the Better Medicare Alliance. This is the industry group for Medicare Advantage. And they say, look, like you're thinking about it the wrong way. We have significant out-of-pocket cost savings for our beneficiaries and better outcomes for complex patients. So you still unresolved. And so you kind of like you try to weigh these things out. Another thing that people have been talking about recently is skin substitutes. And
Oh yeah.
so Q3 2024 spending for Medicare Advantage was $192 million on skin substitutes. That seems like a lot of money to me on skin
Hmm.
substitutes. I'm not a skin substitute manufacturer, and so I could see how they might feel like it was not enough money. But if you look at Part B skin substitute spending for that same quarter, it was $2.9 billion dollars. And so, like, a compelling argument you could make in this era is, well, there was a whole lot of less, like, assuming it's roughly the same populations, Medicare Advantage did a much better job of managing skin substitute spend than Part B. Like, a lot
Yeah.
better, like a whole order of magnitude.
Yeah. Which makes sense. I'm curious, Martin. One of the things that I in my head have just lived experience. If I know somebody well off, approaching Medicare age, and they can afford it, they are going into original Medicare. They are paying and they are getting access to the docs that they want to access. And that generally seems to be the advice I hear everybody give. Like, if you can afford original Medicare, go get original Medicare. Medicare Advantage seems like a safety net program for if you can't afford going into original Medicare. It's a great option. There's a lot of benefits that are given to you for free at low costs under Medicare Advantage coverage to the point of the Better Medicare Alliance. And it, in large part, is a safety net offering for seniors in this country. Does that show up in any of this data? And how, in my mind, it would make sense that if it's safety net offering, it is probably higher cost population than the well-off population going into original Medicare, but it doesn't actually seem like that plays out. And I'm curious, I don't know what explains that.
It kind of doesn't map neatly, but your intuitions are correct. So The thing about Medicare Advantage is that so the reason why the Better Medicare Advantage Alliance talks about out-of-pocket beneficiary costs is
Yeah.
because traditional Medicare, you have a 20% copay on everything. And you can get Medigap insurance, but you're still paying money. You're paying premiums every month. If you get Medigap insurance, you're paying two sets of premiums. You're paying the Medicare premium and you're paying the Medigap premium. And so a lot of it has to do with your household cash flow situation. If
Yep.
you have if a few $100 a month is like not stressful for you, then yeah, original Medicare is probably a better deal actuarially, assuming you can afford it. But if you can't afford it, or if you just don't like spending $200 a month, Medicare Advantage offers you something which is free in most cases. And so there's a high degree of personal preference there, and it doesn't map quite onto like higher socioeconomic status always goes towards, original Medicare and vice versa. But
Yep.
it is the case that if you have cash flow problems or are on a fixed income, it is a lot easier to pencil in $0 in premiums than it is for, your 200 some bucks a month.
Yep. Uh, Seems nice.
Yeah. So there was a quite a bit of conversation this week about healthcare jobs, and you had a nice bit in the newsletter talking about this. It seems like the conversation right now and in the moment we're in is all about how AI is automating everyone's jobs away, and especially, I mean, I don't know if it's just a selection bias thing where you and I are reading healthcare stuff all of the time, but it does feel to me like every startup is promising to automate some piece of the healthcare economy jobs in the healthcare economy away. And yet, almost all of the job growth in the United States is coming in from healthcare jobs. So what do you make of that?
I have no idea, Martin. I can't say I've ever looked in depth before at a jobs report from the Labor Department, but it was certainly interesting. 130,000 new jobs in January. As you said, almost all of them were healthcare jobs, split across 50,000 roles in ambulatory health services, 18,000 in hospitals, 13,000 in nursing and residential care. This compares to 2025 when there were 33,000 jobs created per month in healthcare over the same period of time. I'm looking at a Wall Street Journal chart that doesn't have the exact number, but it looks like overall job loss in the rest of the economy is around 300,000. And I'm like, to your point, if the AI narrative plays out, the job loss for the rest of the economy actually makes a ton of sense to me. And it matches what I kind of generally hear about friends who have kids graduating college who are struggling to find jobs anywhere right now. Yet healthcare is sitting here as this outlier, which is just kind of the nature of healthcare being an outlier in a weird market in so many ways, right? Yes, we have heard so many pitches 2025 and 2026 about how automation companies are coming into incumbent healthcare and are going to 10x the amount that staff can do, which, if that is the case, should be reducing the amount of people needed behind the scenes, right? Like that, the whole chart about administrative jobs exploding in healthcare over the last several decades, AI should be the thing that fixes that and gets rid of administrative jobs. And the people running the companies with the administrative jobs should actually be incentivized to move that along quickly, right? Like they get more margin capture by automating stuff and automating away roles. And yet, nonetheless, despite all of the investment and all of the press releases we heard last year about AI automation taking off in healthcare and how health systems are transforming their back office and how provider practices are, yada, 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 we have this jobs gain. And I think that like the only conclusion I can come to is that what is actually happening behind the scenes is not automating away jobs. Rather, it's capturing incremental revenue, which allows you to operate the way that you are. Like I've heard of rev cycle management companies whose whole thesis is you basically hire people to train the AI algorithms how to work. And so there's a model in which I can see you're actually hiring more folks in these environments, which unless that's just a very short-term blip while you're training models and using them to data label and so on and so forth, which I find hard to believe. Like you're going to bring in all these people and then you're just going to like conduct mass layoffs once the model works well enough. I don't know. Maybe I'm naive in that. We're not reducing healthcare costs on this trajectory, right?
Yeah. So I think there's sort of two questions buried in here. One, will AI reduce healthcare costs? You and I think, are both pretty much in the camp of no. There's a funny study which looks at the amount of bank tellers in the US pre and post the introduction of the ATM. And the funny thing is that like it went up. The
Yeah.
number of bank tellers went up. It's like we got richer as a country. The financial services got more complicated. And so we ended up even we ended up having to hire more bank tellers, even though
Yeah.
we have ATMs. I think, you can say, okay, yeah, that's approximately what's going to happen in healthcare. And that ties into my second question, which is this good or bad? So you wrote, give me a second here to make this connection, but you wrote a little bit about longevity guru Brian Johnson in the newsletter. And he launched a product about, saying $1 million a year longevity product called Immortals. I think that like what we're seeing is at the very high income strata, people are wanting to spend more on healthcare, and there is absolutely people willing to fill that demand. My
Mhm.
sort of theory about the United States is when you are a sufficiently affluent country, you also want to like people who are signing up to give Brian Johnson $1 million. Like you as a country want to spend more money on healthcare.
Mhm.
And so it's not bad. I mean, it's I don't know. It's like I kind of can't imagine a better thing to spend money on than healthcare. Like if we're gonna spend some crazy percentage of the GDP on something, like nearly 20% of the GDP, healthcare is a pretty cool thing to spend it on. Like we have so
Yeah.
many amazing. You and I talk about all of we talk about the biomedical innovations. We talk about the way that, GLP-1s, we talk about all of these like incredible things that we have access to in the United States. And you're like, well, yeah, that's what you get when you spend 20% of your GDP. If you want to spend less, you can have more money for other things, but those other
For
things
sure.
are
Yeah, I there's that stupid meme going around social media right now about spending money on AI data centers because AI is going to cure cancer. And there's a reason why it's curing cancer is kind of the noble cause that's thrown out there. It's because everybody that should be what we aim for. And spending more dollars on building data centers to cure cancer, I don't know anybody who's going to say no, let's not, cure cancer as a result of the AI boom in this country. But yeah, I mean, there's so much to unpack in all of this, right? There's that Jevons paradox that the AI community has been talking a lot about, kind of to your point on bank tellers. As things become a commodity, people use more of it. So you're going to hire more folks. And that's become the explanation for why radiologists actually seem to be doing better than ever, despite being, exhibit 1A of what AI is going to wipe out. Like that hasn't materialized, right? And it hasn't materialized because they're integrating the tools, they're making use of them, they're becoming more productive. The best radiology groups are hiring and doing really well. That seems fairly predictable to play out, and I think it's interesting to see and think about how all those pieces fit together, right? Go back to our conversation on access at the beginning of this conversation. If access is actually able to reduce the cost of delivering chronic condition management across key diseases by what, 5 to 10x by the adoption of technology in a meaningful way, yes, that is going to reduce that part of healthcare costs, certainly, which is awesome. And those costs are going to be reallocated somewhere else into the equation, which ultimately, I think, to your point, is a good thing. Like if those costs then go to curing cancer, great, thumbs up. But I mean, that's how this pot gets redistributed, right? And the profit pools that exist will continue to exist. They will just be doing slightly different things and hiring different people. But like we're not. I think these doomsday scenarios that we're gonna get rid of the workforce are, I don't know, overstated in my head.
It would be the first time in the history of a new technology, but maybe this time is different. Speaking of profit pools, so there's been some payers and some care delivery organizations that have reported earnings in the last week. You listen in a Hinge, sounds like they had a pretty good go of it.
Hinge had an awesome earnings call. I mean, in general, we talk a lot about the narrative between payers and providers right now. Payers, good is just staying afloat, right? CVS, Humana, Oscar, just staying flat and being like, our business is okay, guys, to the investor community seems like a win at the moment. Um, Hinge, on the other hand, is sitting there saying, "Hey guys, we're we're crushing it right now. Not only are we a rule of 40 company, not only are we a rule of 50 company, we are actually a rule of 80 company. We've got combined revenue growth and free cash flow in 2025 of 81%. That's really impressive. Like they are growing nicely. They are kicking off a lot of cash flow. It's indicative of one of the things I'm curious to keep an eye on in 2026 and beyond, which is kind of this reinvigoration of the digital health market. They traditionally been selling to employers. They've been launching Hinge Select, which is their kind of network into in-person care. I think it sounds like those are both going really well at the moment. They're starting to uh, they're winning business from competitors, so on and so forth. So it's going to be interesting to see how they continue to grow the business and how the business benefits from leveraging AI technology over time. They credited that as a big part of what grew free cash flow margin grew from 12% in 2024 to 31% in 2025. Huge growth. They are seeing that, it seems like, through implementation of AI technology, so on and so forth. Go back to access in that conversation we are having. There is going to be I think, a much bigger market pull for them to continue doing that. It's going to be curious to see how orgs like Hinge adapt to that over the next several years over time, if there is indeed downward pressure. Like it's not hard to work through how that might happen pretty quick here. So it's going to be interesting to watch that. But at the moment, man, they're doing really well. Their stock rose, I think, 20% on the quarter, which is interesting because it's almost back at the IPO price, not quite, but like I think it's actually doing a lot better now than it was at the IPO. So what do I know about stock prices? How about Tenet? You spent some time with Tenet.
I love Tenet. Uh, so I mean, and how could you not? So their USPI, which is their ambulatory surgery center, their
Hmm.
adjusted EBITDA margins were 40% last year. They were
That is
39.2%.
wild to me. How do you get it that high?
39.2. Like that's so great for them. Very cool. I'm not jealous at all. And then the hospital. So they have two basic lines of, they have three lines of business. It is USPI, their hospital business, and then Conifer, which they recently
Hmm.
brought 100% back in-house. But USPI, 40% adjusted EBITDA margins, basically 39.2. Hospital is 15.7%. Yeah, it's a good spot to be in, to
Hmm.
be one of the haves in the hospital world. I did a little bit of math, and you look at, their in their peer group, the story for their business is on pricing and acuity versus volume. Volume's up
Yep.
a little bit, pricing's up a lot. And that was true on ambulatory, that was true on their inpatient business. And so is that Conifer being much better at rev cycle than it was before? Maybe. It's also, I think, helps to be a dominant player in all of the markets that they're in, right? Um,
Yep. It is,
that's
it does feel like the potential crack in the narrative over time of if you are a care delivery org winning not on volume increases, but on price increases, at some point the market's going to correct to that. And you can't just continue increasing prices infinitely over time, which seems like it indicates that we're kind of at at peak tenant cycle at the moment.
yes. And similar to HCA, a lot of the Q&A was, "Hey, can you keep this up?" And them saying, "We are deploying a lot of cash for M&A, so we're going to do our best."
That
Um,
is what one does when they have a lot of cash flow coming in the door, right? It's a very logical thing to do. Deploy that cash to buy more cash flow to keep things going. And then you can also kind of predict the downfall over time from that.
yeah, a couple other interesting points there. So they're penciling in about $250 million in adjusted EBITDA headwinds from the expiration of the advanced premium tax credits, the enhanced ones at
Hmm.
least. So they're thinking worse payer mix, which is in line with what we've heard from the other hospital folks. They got a lot more, a handful more questions on the conifer thing, and it was very funny to hear them say, "Listen, the NPV was positive, okay? So if you look at if like letting the contract with conifer play out." Versus the cash that we're bringing in the door, the NPV is positive. I felt like my finance professor in business school being like, if the NPV is positive, you do it. And that's what he always would say. And it's like they're dusting off the NBA playbook. The
Yeah.
last thing is they got some questions about their supplemental payments. These are the payments that Medicaid is authorized, state Medicaid agencies are authorized to give them. And I'm always just kind of curious, like, okay, what are their supplemental payments as a percentage of EBITDA? And for them, it's about 25%. So it's about $1.34 billion total, though
Okay.
in terms of annual, some of that was prior period development. 1.2 billion in annual run rate is what they're looking at for this year. Yeah, it's a pretty big
That's a
part
big
of,
number. Yeah.
yeah. And what they would say is, we lose money on Medicaid patients, but
Mhm.
also not really when it's about a quarter of your consolidated EBITDA.
Yeah, for sure. I mean, this is where it feels like there is a playbook that is working very well for a subset of hospitals right now that does not get a ton of airtime nationally, just given the overall morass in hospital operating margin in particular. But if you're operating in states with good Medicaid rates, if you've got the right payer mix and understand how to do that and select based off of where geographies or where populations are going, so on and so forth, um, and you are implementing technology in new, thoughtful ways, it is possible to run hospitals at 16% operating margin at scale, right? They've got 4 billion EBITDA coming from their hospitals and 40% margin EBITDA margin on their ASCs, which are also generating 3 billion of profit or of EBITDA. Like that, good for them.
Good for them. It's the
Good for them.
nicest thing you can say is good for them. On the continuing our sort of earnings roundup here, on the people who are paying those hospitals that 40% EBITDA margin, Oscar reported earnings. Oscar grew. They grew more. They captured more market share than any of the other publicly traded plans, which we expected.
Hmm.
Um, that they feel confident that their price for profitability this year, we'll see, assuming no big surprises in medical trend. I think that I could see it. A couple of the interesting notes there. So Oscar spent a lot of airtime on ICRA. There were two interesting data points here. One, so they're not sharing their ICRA numbers publicly yet. Bertolini said they're not meaningful enough to share yet. One of the things was, they said that their Oscar, or sorry, excuse me, their ICRA participation doubled year over year. That's a data point that is exactly what basically Rebecca Springer was telling us around
Hmm.
JPM, that
Yeah.
ICRA is growing. It's on a small base rate, but it's growing.
Hmm. Yeah. I mean, I think that is a really good data point for the startup community that is operating in ICRA right now. Like it is exactly what you want. In the community, we've had a whole bunch of questions of is ICRA growing? Obviously, there's the macro headwinds towards ICRA, given the instability in the ACA and the risk around that. And the fact that Oscar is seeing it double. I've seen some other data points on LinkedIn and whatnot that it might have tripled, but that 2x to 3x the market, yeah, it's chugging along, right? That is what I think you would hope for as an outcome given the overall market right now. So
It's
I
so
thought,
much better than I expected.
yeah, for sure. I mean, I think that is heading in a good direction. Now, I am still concerned for Oscar that they, as a public company, are talking on their earnings calls about a market doubling, and it's still not being meaningful enough for them to talk about the size of it. It's I followed Oscar for a long time now since it was just getting up and off the ground, and it has gone through a massive journey over time, right? From the high flying days of being the company that's disrupting the industry to the days where it looked like it wasn't going to make it and had to get Florida to agree to not send them more enrollment so that they wouldn't run out of cash. I mean, it got tenuous for a while there, right? And then Bertolini came in and really righted the ship. And they seem to be operating really well as an ACA insurance plan at the moment, which is awesome. Like they have built a real durable, sustainable business in the ACA. The challenge for them on the flip side of that is that no insurance company wants to be a single product line business on the ACA market right now, given all the uncertainty around the ACA. And this is where it's hard. Like if you're in Bertolini's shoes, if you're trying to lead Oscar forward, how do you think about that strategically? ICRA feels like a nice add-on bet, but it's tough when you're telling investors, hey, the market's doubling, but it's still not meaningful enough for us to report membership. We've got this partnership with Hy-Vee in the middle of the country in flyover land that sounds kind of cool, but we're not reporting anything on it. It's like, okay, then what? But Bertolini's broader point that I think is fascinating that he brought up a little bit with this ICRA topic, I thought, was this idea of decoupling the he called it the investment decision from the financing decision. But basically, as I think about it, the decision to purchase your product from how that product is paid for. And it's not hard to think about where he might be going with that, which is, Oscar's got these cool plan designs for individual population, right? They've got a product for menopause, they've got a Spanish speaking product. I think they've got a few others, maybe a diabetes product, I forget. Um, but you can envision a world where you move the government funded pool to a single risk pool, and anybody across Medicaid, Medicare, ACA, ICRA can choose what plan design they want. And then those programs just are different mechanisms to finance the program. And it's like, that seems pretty logical to me for us to move in that direction over time and a good thing for consumers who get choice competition amongst insurers for product offerings and whatnot. And I'm like, that actually sounds pretty cool. And if I'm Bertolini, that's kind of the thrust of my narrative moving forward. It involves us getting back into the different financing mechanisms that where we haven't, like they tried to get into Medicare Advantage historically, right? That did not go well. Um, so there'll be a lot of questions there, but I think it's an interesting topic of conversation for us to keep an eye on.
An interesting thing to think about if you're Oscar's corp dev team, there are about to be a lot of Medicaid plans up for sale at reasonable prices, and the only other bidder is going to be Molina. Like, do you kick the tire? Because you look at the markets you're in and you say, yeah, like this population is roughly similar to at least some of our book. And there's a lot of back and forth between those two plans. I'm curious what your reaction to that is.
If I'm Bertolini and I've got a corp dev team and we are looking at various opportunities, yeah, that I think is the first thing you got to look at. Like, where can we take what we're good at and apply it to adjacent markets? I think you're looking at both Medicaid and Medicare Advantage plans as opportunity sets, and they would be really big jumps. So you need to be thoughtful about how you're doing that and who you're partnering with to do that and how all of that works together. But I would be shocked if it's 2028 and we're still sitting here and Oscar is just an ACA slash kind of ICRA thing. Like they've got to figure out what their next big jump is, and that's either acquiring to get into one of these adjacent markets, or it's merging with a larger entity, or it's building de novo product to get back into them. They've seen the de novo product build in MA. I don't think you're building a de novo product in Medicaid. Like that seems tough. you getting into the employer market? I don't know. Like I think you stay in ICRA. I don't think you go upstream of that. So, anyways, that's I think yes, your corp dev team is looking at all of that. And then I think you're evaluating how does the market react to that if we all of a sudden enter, you know, pick a state Medicaid plan that I might wait a year, I guess is my my my
Let's let the
reaction.
dust settle a little
Yeah.
bit.
Yeah. Give it some time. But listen to
Yeah.
what Molina's talking about on their earnings call about the acquisition opportunities and take a look.